Welcome to Applied Kinesiology Introduction. My name is Dr. Alan Jenks, and I will be taking you through the introduction of Applied Kinesiology. Along with my partner, Dr. Jim Townhill, I would like to welcome you to the online version of our Applied Kinesiology course. We are looking forward to seeing you in some of our workshops, but for now, I want to take you through sort of the basic ideas behind Applied Kinesiology so you get a sort of standard basic idea of the concepts and some of the basic ideas we will teach at our workshop and online. The following is an original compilation of Applied Kinesiology works, theory, hypothesis, and practical applications. The material has been compiled from a broad range of reference texts, papers, and original writings of some of the greatest teachers, researchers, and innovative thinkers of the last century. Due recognition and our eternal thanks goes to Dr. George Goodhart for his discoveries and his life work and inspiration, which changed not only our lives, but that of thousands of others. We would also like to thank the many other diplomats and doctors, too numerous to mention, who provided us with the basis and original ideas that have broadened the basic understanding and knowledge and information necessary to create this work. I want to start off this introduction from a quote from a friend of mine, a chiropractor, as well as a applied kinesiologist, Eugene Charles. He said that love of the procedure is the tool of the technician, but love of the patient is the tool of the physician. I love this quote because it really summarizes essentially what applied kinesiology is. We have a lot of procedures, and our tool is muscle testing. So we're really a technician, but ultimately we're physicians, because at the end of the day, it's really about the love of the patient and really just meeting them where they are at that time and providing as much love and care for them as you can. And it really sort of symbolizes what we do. These are sort of the 6 major concepts I want to sort of bring across as we go through the online modules as well as the workshops, is really my concept of optimal healthcare. It starts by finding the cause. We need to find out what is going on with the patient. And then what we need to do is use our skills to induce rapid recovery by picking the proper technique to fix that person. And by doing that, we want to give lasting correction, which will end up just naturally developing lifelong referrals. It allows us to be more effective, as well as for the patient more effective with their time and their energy and the right tools. And it ends up allowing us to give more than we get. And then this cycle continues, and it allows us to be prosperous for the future. Today we're going to talk about some of the concepts and methods of applied kinesiology. We're going to define the triad of health. We're going to talk about the 5 factors of the intervertebral foramen. We're going to talk about the history of applied kinesiology, and ultimately we'll talk about muscle facilitation and inhibition as it relates to the manual muscle test. Applied kinesiology can be defined as the clinical application of the study of movement and function. A colleague of ours, Dr. Wally Schmidt, talks about it as being functional neurology. Eugene Charles says that applied kinesiology is a diagnostic tool of the body's central integrative state through the detection of direct or reflex manifestations within the structure or function of the muscular system. And another friend of mine, Simon King, talks about muscle testing as the body's response to an external force. So we're using these things to help us determine what's going on with a patient. It's a continually evolving system. It provides the doctor with the skills and knowledge to purposefully, systematically, and logically ascertain the optimal treatment for the patient. It embraces the work of all individuals and disciplines who endeavor to diminish suffering of the human, and it attempts to unify such diverse knowledge and techniques into unusable and stable scientific systems. This technique, it changes all the time. It's open. I get smarter and change things up as the years go on, as I understand and better able to apply different technique systems. But ultimately, it comes down to the muscle test. And as we get a better understanding of what's going on with the body, we can use the muscle test to help us better accurately figure out what's going on. Wally Schmidt and Sam Yannick defined applied kinesiology as a clinical diagnostic and therapeutic method that draws together elements of complementary medical therapy, such as acupuncture, clinical nutrition, and manual manipulation, and combines them with mainstream medical understanding of neurology, biochemistry, and other aspects of physiology. It's a diagnostic procedure that focuses on identifying functional neurological changes before they become end-stage tissue disorders. And since the health of the nervous system is dependent on its ability to receive and respond to sensory information, treatment procedures are primarily sensory receptor-based therapies. These are designed to normalize afferentation within the nervous system. It provides you with basic methods to examine functional neurology. And these basic treatments you can then use to enhance more specifically and accurately what you need to do. It allows you to better understand why health problems develop and provide better directions for proper therapy. And it is a system that evaluates and analyzes structural, biochemical, and emotional balances in the body. And we do this all from the manual muscle test, which you'll learn all about in the workshops and online. The manual muscle test can be used to identify nutritional adjustment, exercise, acupuncture, a variety of different things that give us insight to how we need to treat the patient. It's mainly a diagnostic system, so it's not for the most part technique driven. The techniques come from other systems, and AAK just kind of brings it all together using the manual muscle test. You'll use different treatment modalities, but ultimately the manual muscle test allows you to incorporate better precision in how you treat. The muscle test is not an evaluation of strength or weakness, but of the neurological response of the muscle to stretch. AAK is a series of sensory receptor-based diagnostic challenges followed by monitoring of the manual muscle test. The aim is to decrease cumulative noxious stimuli below threshold, allowing the body to heal itself. Brings the patient to a higher level of health and help to actualize their potential. All the techniques in AK are about creating sensory receptor stimulation that results in a net efferent excitation and inhibition, leading to more optimal neurological function. So we're ultimately using the manual muscle test as a way to improve neurological function of the body. The International College of Applied Kinesiology was founded in 1975. There's members from a variety of specialties, including chiropractors, osteopaths, medical doctors, dentists, physiotherapists, manual therapists. Every year, the college puts together a theory and practical-based exam, which is called the Clinical Competence Test, which you do at the end of the sessions or at one of the conferences. We've got meetings that happen both internationally and locally, and each country holds their own annual conference, as well as there's an international conference. At the time of this recording, it's 2018, and the next international conference is in Brisbane, Australia. The annual meetings provide an opportunity to update members with regard to research activities and anecdotal thoughts from its members to help us improve our technique and diagnostic skills. You can find more about the international chapters if you go to www.icak.com. I currently am a member of the Benelux chapter, and you can find that at icak.be. And then one of the larger chapters in the world that has a lot of great information is icakusa.com. So these three things will provide you with different seminars and updates throughout the year. We've got chapters in a variety of different countries, everything from the United States to Australia, Baltics, Benelux, like I said. We've got a chapter in Brazil, Canada, Germany. Germany happens to be mainly medical doctors, that and South Korea. So you'll find that most medical doctors in Germany and South Korea practice applied kinesiology. We've got chapters in England, France, and Italy. I also currently teach the 100-hour or the basic course, which this introduction video will be part of in Italy. We've got chapter in Russia, Japan, and Switzerland. Ultimately, at the end, as you enjoy yourself and really start to enjoy applied kinesiology, I would really recommend that you sit for the diplomate exam. In order to become a diplomate, which Jim and I are, you have to accumulate 300 hours of graduate study taught by 2 different diplomates. You have to write 2 original papers. You have to have been at least 3 years in applied kinesiology practice. And then the exam consists of 5 100-question written exams. Reflexes, nutrition, acupuncture, respiratory, and procedures are the titles of those exams. And then you do a practical exam. And then if you pass those, then you become a diplomate of the International Board of Applied Kinesiology. We're going to learn a variety of things related to functional aspects of the body. We're going to show you how to properly manual muscle test, how to use postural analysis. We'll use the manual muscle test to figure out where fixation and subluxations are. We'll look at muscle testing as a way to improve your psychomotor skills. We'll look at gait analysis when we look at postural analysis. We'll also teach you some acupuncture and meridian therapies and how to challenge the body, both joint-wise and as well as visceral. How to challenge the viscera to see if that's having an effect. We'll teach you how to communicate better to your patient, and most of all, hopefully by the end of it, you'll realize that you're actually having lots of fun in practice. We can use AK, or the manual muscle test, to look at for structural problems, biochemical problems, and emotional problems, and be able to evaluate which is the most important. So does the structure overcome the emotional, or do we need to fix the emotional to fix the structural? We'll figure out how to exactly locate the optimal technique or the location that needs treatment, and after treatment we have a way to analyze whether or not our treatment has been effective. You can use AK, so the manual muscle test, to look at muscular problems, neurological, vascular, osseous, lymphatic, respiratory, digestive, endocrine issues, energy disbalances within the meridian system. We can figure out how to specifically adjust the body in a right way. We'll look at how to apply manual muscle testing to cranial movements, different massage modalities, exercises and stretches, which are the most important. You'll be able to learn how to properly test whether or not that patient needs a particular supplement and if it's going to work. And then, of course, we'll look at emotional issues related to stress and lifestyle. Remember that the universe is not to be narrowed down to the limits of our understanding, but our understanding must be stretched and enlarged to take in the image of the universe and as it is discovered. So I challenge you to keep this quote by Francis Bacon just in the back of your head, and always ask questions, but just keep yourself open. Allow us to teach, and be open to the fact that maybe some of the things that you've learned in the past are no longer relevant, and whether or not start asking questions about whether or not what you believe to be true is actually true, and help us show you how you can actually use muscle testing to help you guide yourself in the most appropriate way. So originally, applied kinesiology got started in 1964. George Goodhart was a chiropractor in Detroit, Michigan, and he started using muscle testing after reading the book Kendall and Kendall, written by Kendall and Kendall on manual muscle testing. They had written a book related to the polio epidemic and looking at ways to evaluate muscle strength based on the effects of polio on the body. Time magazine wrote about him. They called him the man with the magic fingers. And he noticed when he was using Kendall and Kendall's muscle testing that sometimes the muscles tested weak, and there was no known neurological cause. And the first breakthrough came when he made a weak serratus anterior muscle strong by rubbing on painful nodules on the serratus anterior muscle. And that muscle was weak, and then it became strong after treating that. And that was sort of the basics or the origins of AK. That particular technique later became what is known as origin insertion technique, and forms the basis of one of our muscle-related treatment options. From there, he was a prolific reader, read tons of books all the time, and in 1966 he started using neurolymphatic or Chapman's points with the muscle testing. And in 67, he introduced the neurovascular points. In 69, he introduced basic cranial motion and the use of muscle testing with that. 1974 became therapy localization, and then it was he was starting to get quite a following that in 1975 he decided to, with a group of the original teachers, to develop the International College of Applied Kinesiology. In 1976 he introduced the temporal mandibular problems and joint corrections, and in 81 is when Dr. David Walther wrote the first textbook on applied kinesiology. Every year there's new findings discovered and presented. And right now, the ICAK USA produces every year for their annual meeting a yearly review of new things that members have published or thought through. And you can find those proceedings at ICAKUSA.com. In 2008, we've just released again our first international journal, and that can be found by contacting your local chapter. And those journals will most likely come out 2 to 3 times a year. But again, just gives us an update on the newer findings within applied kinesiology. So there could be lots of reasons why a muscle won't test strong. It could be myofascial related, nerve related, spinal segmental problems due to deafferentation. It could be neurological issues within the brain itself, low nutrients, toxic chemicals, cranial problems, meridian imbalances, improper lymphatic drainage, and organ dysfunction can all be reasons why a muscle would go weak. We call this the 5 factors of the IVF, or the 5 factors of the intervertebral foramen. So when we think about a muscle being weak, we want to think of the reason is one of these 5 things. It could be a cranial sacral problem, it could be an acupuncture meridian problem, it could be a nerve problem, it could be a neurolymphatic problem, and it could be a neurovascular problem. This is sort of how George Goodhart sort of narrowed down what he thinks in his mind as a muscle presents itself as weak, what he needs to look at. We could probably expand those right now. EMF would be another source of why a muscle would go weak. And then what we want to look at is when we're looking at those 5 things, we want to say, does it have to do with a chemical problem or an emotional problem or a structural problem? You'll see that structure is on the bottom because that's the basis. So in general, or when in doubt, always look to some sort of structural problem causing that weakness. But again, it could be chemically and emotionally. I guess this would be more in the chronic type of problems. And then we can, from there, think about structural being this issue. Is it a subluxation in the spinal column? Could it be an extremity joint, cranial problems, organ problems, so an organ that's not sitting properly? TMJ is a huge problem for the whole body, and then pelvic instability. These would be all structural issues that we could look at in order to correct why that muscle is weak. On a chemical side, it could be related to allergies, fungal, bacteria, or parasitic type infections, metal toxicity, chemical toxicity, prostaglandin problems such as chronic inflammation, or just digestive disturbances could all cause a muscle to go weak and therefore create problems in your body. Emotionally, it could be related to depression or maybe a phobia, chronic fear of heights or something like that, and it's holding you back. Psychological sabotage, so this idea of thinking that you want to get better, where deep down inside you don't want to get better. And then learning issues. We can use these sort of 4 basic things to kind of figure out what's going on with the body on an emotional side. So just remember that the body has 500 plus muscles, so muscles move bone. So it's really important to be able to monitor the body and see how the body is responding to an external force. And you'll see here that you've got the 5 factors, and then I've thrown 3 down at the bottom there. Think about nutrition, psychological, or electromagnetic field radiation as being other reasons why potentially the body's not functioning properly. Neurologically, it could be related to a subluxation, so a joint that's not moving properly, or a fixation, which is multiple joints not moving properly, or it could be related to an extremity joint, so an ankle or a wrist that needs to be adjusted in order to get that strength back. The second of the 5 factors are related to the neurolymphatic points. These were developed by an osteopath in the 1920s named Frank Chapman. He used to help lymphatic drainage with within the stimulated organ. It's all based on empirical data. You find them anteriorly and posteriorly on the body. And our treatment of these points is just simply going to be stimulating by rubbing these points in a firm way for about 30 seconds. I refer to them as Chapman's reflexes, but you'll find other applied kinesiologists refer to them as neurolymphatic reflex points. There's really no conclusive evidence as to whether or not these points actually have a tie into the lymphatic system, but they seem to be really important for organ dysfunction. And so, from that perspective, I probably just refer to them as Chapman's reflexes. Goodhart started using them in around 66, and you stimulate the point, and then he found out that sometimes it would help a muscle become strong. It helped him further develop and figure out the organ-muscle relationship. So you'll find out throughout the course of these workshops is that every muscle has a relationship with an organ. So there, like for instance, the teres minor muscle is related to the thyroid. So there's lots of these different combinations, and as you start using this technique more and more, you'll remember them because you'll be using them so often. And then the organ and muscle drainage occurs with stimulation. So the idea being here is that when we stimulate these points and rub them, that the organ and muscular system is being stimulated at that level and is allowing to clear the lymph. Now, whether or not this is true or not, we don't really have any evidence on that. Points are active when you feel a swelling over the area, and usually painful to rub anterior and posteriorly. Usually the anterior points are worse than the posterior points, and oftentimes the greater the pain over that reflex point, the greater the chance that it's a nutritional problem. And often what you'll find is when you get the right supplement, it'll reduce the pain at that neurolymphatic point pretty consistently. Then we got neurovascular points. These were developed by a chiropractor named Terence Bennett in the 1930s. They mainly are found on the skull, and stimulation of the points increases blood flow to the related organ. They are thought to be remnants of the vascular network, which augments the mother's placental circulation before the heart is formed at about the 4th month point in gestation. So the idea that these points were a way to carry blood before the heart was actually specifically functioning. So it's like our secondary heart. It can be stimulated via light pull and feeling of a pulse for about 20 seconds. So you just put your fingers over that area, do a nice light pull, and then wait for the blood pressure or the heart to equalize on both sides. Goodhart introduced this around 67, and again, the neurovascular points were also used like the neurolymphatic points to confirm the different organ-muscle relationships. And the idea here is that there's an embryological relationship with the circulation, as it was found the pulsation on the point was unrelated to heart rate. So because it was unrelated to heart rate, they want, you think you go backwards, and it probably has more to do with how we develop as a baby. And we can use other localization points to identify whether one is there or not, or whether the neuromuscular points are primary. Then we've got the fourth factor of the IVF, which is acupuncture or the meridian system. Acupuncture has been around about 5,000 years, or it's probably more than that now, and it's based on the premise that the man is a microcosm of the universe, and the same life-giving energy connects us to our environment. So energy, or chi, what we call it, flows throughout the body in distinct pathways called meridians, It's the oldest known reference tech in medicine had to do with acupuncture, and it was called the Nai Chin, written between 2696 and 2598 BC. Within particularly the Applied Kinesiology course, we're going to look at the 12 different meridians, plus the 2 central meridians. We'll look at the 24-hour clock, the sedation points, the tonification points, the alarm points, and the 5 element charts, and get an understanding of when we can use the acupuncture system to treat the patient. Then last but certainly not least is the cranial sacral. So the idea of the bones in the skull moving with the bones in the pelvic area. And these have been monitored and studied pretty profusely. And so we have movement that occurs in the head and the pelvis. And so we're going to use our manual muscle testing to help us determine where to treat. And the reason why this is important is because of the cerebral spinal fluid. So initially, Goodhart got some books from an osteopath named William Sutherland, who was introducing cranial adjusting, and started applying this with the muscle testing. Imbalances can alter function of any muscle or organ, so we usually start with this in the first weekend because it's pretty important to get the sacrum and the skull lined up and moving correctly in order to make any permanent changes. And we're going to challenge these cranial issues with breathing, so different breathing patterns, and we're going to treat with direct pressure as a patient respires. So usually we're going to find a contact point and we're going to adjust that point with either a patient breathing in or out, depending on what the manual muscle test is saying. Nutrition came about from Goodhart as he worked or took over his father's practice, who was also a chiropractor, and they were heavily into nutrition, very much influenced by a Dr. Royal Lee, who was a dentist in 1937 and started the company standard process. And usually what he would find is that tasting of different nutrients on the tongue changed cardiographic recording within 10 minutes. And George Goodhart took that idea and thought, well, I wonder if we could just test the muscle and see if there's any change with it on the tongue, because he knew that in 68 they show this direct connection between the tongue and the food centers of the brain. So he just kind of always thought about this combination of, well, if a cardiograph is making changes, certainly we could see that in the muscle strength or not. And so in order to evaluate these 5 factors of the IVF, we need to look at 3 things. We need to learn how to muscle test. We also need to learn how to therapy localize to help us develop what is and where is the treatment needed. And then we want to look at and practice the idea of challenge. So moving the body in certain ways in order to induce change. Therapy localization was developed around 1974, and the idea here is that you're going to get either inhibition or strengthening when you place your patient's hand or your hand over the area that potentially needs to be treated or in dysfunction. Muscular facilitation is only located by placing patient's hand over dysfunction related specifically to the inhibited muscle being tested. So it essentially therapy localizing, when we have our hand on a body part, it's revealing potentially where the problem is, but not what it is and how we're going to treat it. It does not replace standardized examination procedures, but can cause a muscle to weaken or a weak muscle to strengthen. And as a result, we can plug this technique system in at any time. So there's really no fast rules about when or where to start with this. Challenge is something that we're going to do to get more specificity or more detail in how we're doing things. So we can apply an external vector of force in a direction that causes a change in muscle facilitation, and we're affecting joints and the muscle in that area and the mechanical receptors. So what happens is there's this intense deafferentation from improper joint mechanics, which affects the central nervous system. A challenge disrupts this central integrative state and temporarily causes a neurological inhibition of any normal functioning muscle. Again, this can all be explained via the idea of proprioception. Nutrition-wise, we can actually map out the specifics within the brain of how this happens, but essentially the tongue or the gustatory receptors on the tongue feel for a food, triggers things within the foramen, such as the cranial nerve, to stimulate the thalamus and hypothalamus, which then signalize the reticular formation and the reticulospinal tract, ending up resulting in a change in the anterior motor neuron. And what happens is essentially we activate the thalamus, hypothalamus, which then develops a spinal cord-based receptor response. So muscle testing itself really got started around the time they had lots of polio cases, and they needed to find a way to accurately see if the patient had any strength-related losses. And in applied kinesiology, we're measuring the excitation level of the neuromuscular junction. It gives us an indication of motor neuron activity of the corresponding anterior horn cell. So it's really looking at whether or not the anterior horn cell fires and functions. And when we test a muscle, we're not testing for strength, but its functional ability to respond. What we want to make sure we do is we want to approximate the origin and insertion of the muscle. We want to avoid contacting the body unnecessarily, so it has to be light and specific contact. We adequately stabilize the patient. We instruct the patient first about what they have to do, whether it's a push or a pull. We try not to overpower, but we let the patient initiate their movement, and once they've initiated their movement, we want to start increasing our response. And if we come to a place where it locks, or you can't beat me or I can't beat you in the test, then that would be considered strong. We want to make sure that we are aware always of operator prejudice, so either from patient to patient, pushing one strength with one patient and another with the other, and making sure we're using good form and proper procedure all the time. And we also want to make sure that we observe if the patient is trying to change or the parameters or manipulate the test by bending apart or not particularly holding that limb in the right aspect. And we also want to make sure that the patient's not holding their breath, because holding their breath could indicate that there's a cranial problem. And you want to, as best you can, keep the patient's hands off the body unless you're using their hand to therapy localize. And we're going to coordinate the timing so that the doctor initiates the test after the patient has done the test themselves. Here's an example of the hamstrings muscle test. This is Dr. Scott Cuthbert. Here you see Dr. Hans Garten also testing the hamstrings, and in this case the patient is actually therapy localizing her pelvis. So that's an example of therapy localization followed by manual muscle testing. So when we test a muscle, three things are going to happen. Either the muscle is going to test strong, or what we call normal tonic. This means that the muscle weakens with stimulating a sedation point, or the muscle weakens with spindling down the muscle, so pushing into the muscle belly. The muscle test could also test weak, or what we would call hypoactive. So there's no locking of the muscles. It is easy to push the joint or the limb in full range of motion. But then we can also have a third variant, which is when the muscle test is too strong, or what we call hyperreactivity. Nothing seems to weaken this, and we need to think more systemically. So what's going on within the body that's causing this? And from here you can see in this chart that we just talked about the different processes, what happens from a normal muscle response to the muscle fails and turns off as expected, to what's happening at the spindle cell area, and whether or not we need to take into account or look at different agonists or antagonists to this. And then also we want to look at inducing challenges to see whether or not the muscle changes or not. And these are all the different words we want to use. So sometimes you'll hear Jim and I talk about inhibition, and then other times we'll talk about weakness, or we could talk about too strong or hyperreactive. So just take note of these words, how we've written them, what we would generally call them, or how we would refer to them. But this document will change all the time as well. Starting position for a muscle test is really important, as it isolates the muscle as much as possible by moving the origin and insertion together. And when the patient pushes and we push back, we generally want to make sure that the patient is testing in an arc around the pivot point of whatever particular. You want to make sure that you adjust your strength to suit the patient. You want to make sure that you have enough leverage in order to monitor the strength and measure it. You want to try to get 100% of the patient's ability without really causing any pain. And you want to try not to worry about the subtle weakness and look for true weakness. And so what happens when a patient actually pushes against you or starts the initiation of the test, and as you start to resist, you'll start to feel that if there is true weakness, that the patient won't be able to maintain that. There's going to be some things that you need to take and monitor while you're testing the patient. Often you'll find that patients will activate synergists to those muscles in order to overcome or hide the weakness. So they'll recruit different muscles, such as the biceps, in order to monitor strength of the arm when you don't need the biceps. The patient will try and alter the test by moving their arm or limb in a different direction that is not in the direction of the test. They'll alter the direction, so you'll ask them to go in one direction and they'll go in another one as they recruit other muscles to help. Also, you want to make sure that they don't go into cramp. Cramp is often a signal that the muscle is weak, but if they go into cramp and you monitor it as weakness, it may not necessarily be the weakness, so you just got to be cautious of cramping. And you don't want to push too fast. You don't want the patient to push too fast. So this idea of erratic movement, you want to avoid. It needs to be a slow and progressive steady increase. And you want to make sure that there's no alteration in body position, whether that be you or the patient. The patient may recruit other limbs or other muscles lower in the body to try and recruit and overcome what is ultimately a true weakness. You want to make sure that you compare the muscle bilaterally. Always look to compare one side to the other, because bilateral weakness can actually indicate that there's something sort of greater going on. Always expect some weakness, but try not to judge. So always expect that somebody will have some weakness, but really just keep your mind open to that idea. Protect yourself first. Make sure that you as the doctor are in the right position. And give your patient time to respond. This is often a mistake I see when I'm watching people muscle test, is they don't give the patient adequate time to initiate the test. Always try to keep your forearm in line with the test and move the muscle in an arc. Always think about when you're testing a muscle that you're essentially moving it in an arc rather than straight. And your forearm, or setting yourself up in a position where the forearm actually can be the line of drive of where you want the muscle to go. So then the question becomes, what exactly is this idea of the muscle test? What is it that we're actually monitoring? And I was reading some research in the last couple of years, and there's a group out of Colorado, I believe. It's Roger Anoka and Dechateau. They looked at this idea of cortical excitability changes with eccentric contractions. So it appears that the spinal and cortical spinal excitability are reduced in eccentric or lengthening contractions rather than shortening or isometric contractions. So there is this difference in cortical excitability. So what this seems to indicate to me is that as we're asking the patient to initiate the muscle test, when we actually feel that there's a weakness going on there, and then we push through their initiation, we're actually in a way monitoring this eccentric contraction. And so we're actually monitoring this spinal and cortical spinal excitability or non-excitability. And that's exactly what we're looking for. And so anything that we do, whether that be therapy, localization, or challenge, we're looking to see if that changes this spinal and cortical spinal excitability. But muscle testing, when we apply it with precision, when applied kinesiology practitioners who've been trained in muscle testing do muscle testing, it becomes a very precise functional neurological assessment. It is really an integral part of any neurological exam, but now we've got a way to actually look and assess at these changes in the body and what's going on at this receptor base idea. So as we challenge the body and look for changes in the muscle test, we're essentially challenging the receptor systems and looking at what makes those changes and identify what potential proper treatment is needed in this patient case. We're essentially evaluating the nervous system and its tone or its ability to facilitate the skeletal muscles via this spinal cortical spinal excitability in this eccentric movement. And the nervous system is really just always constantly monitoring, and so we want to tap into that and find out where it's not monitoring properly. And we want to look at where in the body it's not functioning properly, because we essentially have this window to this what's called this central integrated state, this idea that the brain is always monitoring. And we can change the effect of the nervous system quite quickly when we have the muscle test, because we can identify what stimuli is not making the muscle respond and what we need to do in order to make it go strong. And we can use it as a sort of window or monitoring tool to allow us to see into the brain and find out what we need to stimulate receptor-wise in order to bring the body back on strong. A change in the manual muscle test response is ultimately due to changes in facilitation and excitation and inhibition at the anterior horn motor neuron pool of the muscle in question. It's basically AK or muscle testing is about excitation or inhibition of neural pathways. It's about this making sure that the central integrative state is giving the muscles the proper information to respond. It's about these receptor-based dysfunctions that are happening at the cortical spinal tracts and looking at what we need to do in order to stimulate these reflexes and receptors in order to get the body to respond properly.